So we welcome Dr Caroline Marfleet, the Advanced Menopause Practitioner Consultant in Sexual and Reproductive Health, today to our Berry Physio podcast. Dr Caroline Marfleet has been a consultant in sexual reproductive health for 25 years at Colchester Hospital, responsible for contraception, subfertility, menopause and unplanned pregnancy. One of her specialist interests are menopause and HRT, and Dr Caroline Marfleet runs clinics both remotely and at the Nuffield Hospital, Ipswich, and also sees complicated menopause patients at GP surgeries in Colchester. It's an absolute pleasure to have her on our podcast today and an honour to discuss all things menopause. So thank you once again, Caroline, for coming on to our podcast. We'll start with asking you just about the definitions of perimenopause and menopause, because I still think, although the media is improving the awareness of menopause and what the symptoms are, some females are still a little confused about the differences.
It is confusing, I have to agree. The actual word, the menopause, comes from the Greek or Latin, menses being periods and pauses being stop. So it actually means the last natural bleed that a woman will have in her lifetime. And the average age of this is about 51 and a half for Caucasian women. It can be a few years younger in Afro-Caribbeans and Asian women, which is interesting, about 4 or 5 years younger. So that's the actual, what the menopause is at an average age of 51. But of course, the range of that is 45 to 55. Okay. And obviously there are women that will have the menopause outside that range. The menopause is caused by loss of ovarian function and therefore loss of estrogen. And estrogen is a very important hormone for the good working of many of the parts of the body. So we miss it in lots of different ways. The perimenopause is really that period of time that starts often sometimes 7 or 8 years before the final bleed, when women start to notice that things aren't quite right. So it may be some flushes and sweats, it may be some anxiety, it may be brain fog, or irregular menstrual cycles. I suppose obviously if a woman's had a hysterectomy, it's less clear, or if she's got a Mirena coil in which stops periods, it can be less clear. And it can be disguised by the contraceptive pill if she happens to be on the contraceptive pill. And obviously, if she has her ovaries removed, she will go straight into the menopause at that point. And that can be quite an abrupt, severe one. So many women will start to get symptoms of the menopause from perhaps even the early 40s onwards. And when they've had their last natural bleed, we know that they're in the postmenopause and they'll be there for the rest of their lives, basically. The ovaries will never work again. We have to be pertinent that some women might have a premature menopause. We call it premature ovarian insufficiency now. And this happens to about 1 in 100 women under the age of 40 and 1 in 1,000 women under the age of 30. So it's not unknown. So that's a brief description of the menopause.
The perimenopause, even though there are different forms of contraception, Caroline, in clinic I've seen a mixture of women's health patients, and some are obviously on contraception, some aren't, and then some will mention different symptoms and often be unsure what's contributing to them. So is that something that they can still experience even though they're not ovulating?
It can be very confusing with contraception. I mean, the Mirena coil will stop periods, but it won't stop flushes or sweats or anxiety or brain fog. So that's possibly a little bit easier. The combined contraceptive pill, the sort that has estrogen and progestogen in, hides some of the menopause symptoms because it's got estrogen in. But if a woman is taking it in the usual way with a week's break, then they may find the menopause symptoms come into the week's break. But you know, some menopauses are picked up when a woman stops the combined pill. Women on progestogen-only pills or implants, things like that, they can get symptoms because it doesn't contain estrogen, so they can get flushes, sweats, but again, may not notice it because their periods have stopped. So you're absolutely right. Yes, it can be very confusing sometimes.
And I think I've often heard women sort of refer to obviously their week's gap in their contraceptive pill as a period. which, you know, technically isn't true, I suppose, if they're not ovulating. So would you correct that sort of information, or do you just sort of allow them to feel that they're having a normal sort of bleed?
I suppose in medicine we call it the withdrawal bleed, because it happens because you've withdrawn the pill for that week. So it's not the same as a period at all, and women shouldn't ovulate on the combined pill.
And is that a healthy approach? And would you advise that you know, you often ask sometimes by medical, have you been on a contraceptive pill? Have you been on it for more than 10 years? Are there risks associated with these kind of uses of contraception, or is it promoted because the evidence is there for being protective of the ovaries?
There can be some really good reasons to carry on with the combined pill, so long as you have no other, you know, you're not a smoker, you're not overweight, you don't have migraines, things like that. We know that it really does regulate bleeds and reduce the amount of bleeds. Virtually all pills will do that. And of course, generally, periods will get worse as women get older, nearer the menopause, heavier and erratic and prolonged sometimes. So that's a real advantage. It probably gives some protection to bones, as HRT does, bone density. It's certainly, we know very clearly that the risk of cancer of the womb, cancer of the uterus, cancer of the ovaries, and cancer of the bowel are all reduced by having the contraceptive pill. And arthritis too, it's better. So there are a lot of good reasons to carry on with the contraceptive pill. And certainly if you have no reasons not to have it, then it can be a good option. There have been some studies recently suggesting that with both the with the combined contraceptive pill, and more recently with the progesterone only pill, that there may be an increased risk of breast cancer. That the Faculty of Sexual and Reproductive Health has looked very carefully at these, and if there is a risk, it is absolutely minimal. You know, so it's not very clear cut. They were observational studies, so that probably is the only downside. That there are a lot of good reasons to carry on with it, but you need a healthy person, I suppose, and not someone with other risk factors.
Definitely. So talking about what living healthy and what women can do for themselves entering the perimenopause and menopause, what would you advise? We understand there's quite a lot of strong evidence for use of calcium supplementation. Is that true? Are there other things that we could be doing as females going into that stage of life?
If you're having a good, healthy diet, you shouldn't, and it doesn't have to consist of dairy if you don't like dairy and cheese, and because there is calcium in green vegetables and other things as well. So if you're having a good, healthy diet, most women will not need extra calcium. And I think, you know, that's what we all ascribe to, really, isn't it? You know, lots of fruit, lots of vitamins, a bit of fish, a bit of meat. If you, I mean, you know, you have to be careful if people are vegan, I think, because then they're more at risk of losing some of the vitamins and minerals. But a good, healthy diet, we don't recommend fad diets and things like that. That can be catastrophic. You know, if you do need to lose weight, I spoke to a lady actually this week who's really lost 2 stone over a couple of years by losing ½ a pound a week, and that's ideal because she's more likely to keep it off that way. You know, she's done really well, so I'm very pleased for her. But I suppose one thing that I do often talk to women about is vitamin D, because I in the northern hemisphere we don't get enough sunlight and you know, on lovely sunny days like today we're sitting in offices and not getting any at all. So I think that might be worth considering. And it's exercise is important. The trouble with the menopause, if you're feeling really tired and you're not sleeping well and you're lethargic and you're anxious and you're irritable and you're cross, it can be difficult to get on your bike or get out with the dog or go swimming.
So at what point do you often find women come to you in your clinics? Are they usually at the very start heavy bleeds and sort of desperate for help and wanting to go on HRT, or do they commonly try and struggle on a little bit longer before coming to you?
Quite a variety of all that, actually. I think a lot of women are better informed now, and so they're coming along earlier. And I've been speaking to a lot of women in their very early 40s about, changes that are happening to them. Similarly, I've spoken to a lot of women in their late 60s and early 70s, wondering if it's too late to start HRT because of the scare stories about it about 20 years ago. They missed out on getting it then. So, it's quite a wide spectrum, really, of women coming up. And some women like to see if they can go through it naturally. So they'll, look at the diet and try and do some exercise and perhaps go to Holland and Barrett and get some vitamins and minerals. And I had a lady the other day who'd been doing that for 3 or 4 years, and it just wasn't having a good effect. So then they talk about it. I mean, I think it's great that it has become easier to talk about it now and more acceptable to talk about it. And women are getting better informed as well.
Some of that is down to the media coverage as well, isn't it, at the moment? Is there anything we should be cautious about what we're hearing in the media at all?
There can be sometimes. I mean, I think you wanted to talk about HRT and dementia. Because I'm on Twitter and do things like that, I don't tweet much myself, but I like seeing what other people are tweeting about. There's been quite a lot about it on it there. And I've seen some quite high profile women on there talking about the dementia studies that were published recently. They were published at the end of June from Copenhagen, saying that really it was a load of nonsense and that HRT has been shown to help dementia. And I think one has to be very careful about this, is not medical people talking about types of studies, because there are so many different types of studies, from observational, cross-controlled, randomized, prospective, retrospective studies. And you have to know what you're talking about, really. I think the situation with dementia is very unclear. I certainly wouldn't say there's any risk of it causing dementia or aggravating it. But I think there probably is good reason to suggest that HRT could help to prevent some neurodegenerative disease, particularly if they're caused by vascular problems, because we know that estrogens improve vascular flow generally in the body. So yes, I think you have to be a little bit careful what you read in the media and make sure it's coming from a good, reliable source.
Caroline, if someone was looking at starting HRT, what would the sort of typical first-line treatment options be? And does that vary if they are currently on any forms of contraception versus not having been on anything for a period of time before they consider it?
It can be affected by if they're on contraception. I mean, if they've basically, HRT comprises, for women with a uterus, an estrogen and a progestogen. Okay. And so if they've got something like the Mirena coil in, then they can use that, so long as the Mirena was fitted less than 5 years ago previously, then the Mirena coil will provide the progestogen component, and you just need to give the estrogen. If someone's on something like the progestogen only pill, that is not licensed to provide that same protection. So you have to be a little bit careful what you're doing, but it doesn't mean they have to stop the progestogen only pill. They can just have an estrogen and a progestogen as well. And that's not overdosing. I mean, they're very mild, these. So the estrogens that we use in HRT are really virtually all in the UK body identical ones now, whether they're tablet, patch, gel, spray. The progestogens are quite a varied bunch, each with their own characteristics. So we have some that are synthetic, that tend to be more androgenic, and we have 1 or 2 that are body identical or body similar. And so I suppose when you're talking to someone, I always want to take a full medical history and a full family history too, to make sure there's no risks of blood clotting in the family, or stroke, or heart disease, or cancer. And based on that, I will then, I suppose, assess what that woman will want or need, or what might be best with. There are no blood tests that will tell you what dose you need. You've got to go on that by using perhaps standard doses and then working up or down from that. So I know there's a lot of patches, transdermal HRT, which is patches and gels and sprays, are very popular at the moment, because everyone thinks they don't increase the risk of blood clots, and they're easy to use, and they've been championed by Davina McCall and Liz Earle and lots of other people. There is a lot to be said for having tablets, I have to say, for the right person. And we don't tend to use tablets if you're a migraine sufferer because of the risk of aggravating migraines, or if you're very overweight. But for a lot of women in their, let's say, 40s who are fit and fairly healthy, a tablet can be very easy and very convenient. And you know, that they can often be combined with both the estrogen and progestogen, so that you don't have to remember to fiddle around and do one for part of the month and one for the whole month. Does that make sense?
Oh yeah.
That's really clear.
It just highlights how varied, you know, treatment options are and how individualised really they.
Oh, it really is, because they're all different doses, and you know, you know, we need to make sure that we're giving the right amount of estrogen to manage the symptoms, and that we're giving enough progestogen to balance the estrogen and protect the lining of the uterus, because that's what the progestogen does.
So how is that monitored? Is that through how patients are feeling, or repeating blood tests? Because you said it's quite tricky.
Well, I suppose if a woman settles onto it and it sorts out her symptoms, and you know, the HRT regimes that we use for perimenopausal women will give her a bleed every month generally. So you want to make sure that she's not bleeding too much or too heavily, or and she's happy with it. But if if it's not controlling her symptoms, or it's not, you know, the bleeds are not very good, or things like that, then that's when you might want to try different doses, or move around, try different preparations. So we usually advise women to try it for 3 months and monitor it, see how it goes. If they were taking it, it's easy to talk about flushes because they're a very, you know, they're a good marker of the menopause in a way. And so if a woman comes along and she's got bad flushes and sweats, and you give her some HRT and they're perhaps a bit better, but they don't go completely, you might want to increase the dose. And it might be you increase the dose and she's still getting flushes and sweats, and you might sort of think, well, why is she doing that? At that point, you may want to do blood tests for estrogen to make sure that she's absorbing it properly and it's getting into the system, because different types of HRT will absorb differently. So we don't routinely do blood tests, but we can do if necessary.
And what options are available? So patients who've gone through cancer, I understand that they are not suitable to take HRT. So what options do they have? I
suppose the really difficult one is usually breast cancer. If women have a very high risk of breast cancer, or they have had breast cancer themselves. Most other bad medical conditions, I mean, I have given HRT to women who've had a heart attack, you know, or a blood clot, or have got high blood pressure, because by giving the right sort of HRT, you can often help to manage what's happening. But breast cancer is a really difficult one, and particularly most women will be advised certainly never to think about hormones for 5 years after their diagnosis, until they've been through treatment. I have in the end given HRT to some women who are a number of years post breast cancer, and we've looked at it, and because their quality of life is so poor. But yeah, if they, you know, obviously for other breast cancer women, there are some other drugs that can be useful. Acupuncture has been shown to diminish flushes and sweats. It's not recommended to have things like black cohosh or red clover, but antidepressants can actually reduce flushes and sweats, and they can be recommended in this situation. There are drugs called pregabalin and gabapentin that are used for other, and clonidine, that may be helpful to reduce flushes and sweats. Physio, I'm sure, you know, because a lot of menopausal symptoms include a lot of joint aches and pains, so anything that will help in that respect. And I'm a great believer in yoga and Pilates and things like that, and relaxation methods. Yeah. I think it, more than anything, it gives a woman time out on her own, if you like, away from the stress of family life and work life.
Yeah, and is it true that alcohol can interfere with the metabolism of hormones, and so reducing or advising women to restrict or reduce alcohol intake
It
is
doesn't
beneficial?
interfere with the metabolism or absorption really, but I think you have to be careful with alcohol, and certainly alcohol will be worse with flushes and sweats. You know, women, it's one of the trigger factors for a sweat and a flush. But I mean, I think it can be quite easy for menopausal women with the anxiety, the irritability, all those things to go for a glass of wine, can't it? And then a glass becomes two. You have to be careful. And the other thing, I suppose, is that, you know, if you're really overindulging in alcohol, you will have an increased risk of breast cancer. That's been clearly shown from studies, along with obesity. So you need to be, you know, sensible.
Caroline, I've had conversations with some patients where you know, we've talked about sort of menstrual health and perimenopause, and some still feel a little bit conflicted about taking body identical or synthetic hormones, whether that's contraceptive pill or looking at HRT. And I was listening to a podcast by Michelle Lyons, who does a lot of women's health education, and she was talking about how ACOG have classified the menstrual cycle as the fifth vital sign for female body health in terms of looking at good hormone regulation. If a woman's not on contraception and has a good sort of healthy regular cycle, the things that she was sort of mentioning as good considerations for maintaining that are obviously good sleep, nutrition and gut health, hydration, exercise and stress levels. If you had someone who was really sort of resistant at wanting to sort of ingest, if you like, synthetic or body identical hormones, would you suggest trying to manage perimenopause or menopause or menstrual cycle issues with those 5 elements and trying to really maximize health that way, or would you still encourage consideration of hormone input?
I think the menopause is a very different situation to young 20-year-old women on the contraceptive pill who naturally are producing their own hormones, because HRT really is a replacement. And, you know, particularly in postmenopausal women, you're not making really any estrogen at all. We get a little bit from fat tissue and places like that, but we're not really. And estrogen is an important hormone for lots of parts of the body. We have estrogen receptors from the tips of our fingers, if you like, to the top of our brain. So it is a replacement. And I think we all feel that we'd like to replace the hormones with the same sort of hormones that we used to produce, which is what body identical hormones are. And I think, you know, that goes without saying, really. I think it's what is unfortunate is some of the progestogens, we've only got one that's really body identical. We've got one that's body similar, they call it. And because the body identical ones become rather short in supply recently, because it's been so popular, it can cause a problem in that respect. But I mean, I try and tell women, these are just replacement hormones, you know, they're not over and above the hormones that you're making. And they're very mild hormones. They're not the potent synthetic ones that you need to block ovulation, because these women are not ovulating.
So you mentioned some other triggers, Caroline, that maybe alcohol can trigger hot flushes. Any other known ones that you would advise women to try to avoid, like spicy foods?
Well, spicy foods, certainly. Hot food, hot drinks generally, caffeine can, hot drinks, spicy food, curries. But I often think sometimes social situations can do it. You know, if you're going to a party, perhaps, then you're a bit anxious because you want to, you know, enjoy yourself, and you dress up, and you know, and I think even a little bit of anxiety can sometimes trigger a sweat or a flush. And they can be horrendous for some women, you know, literally every 20 minutes during the day and endlessly at night. with great big sweats when you have to change the bedclothes, 2 or 3 times a night sometimes. And obviously, we try and advise on clothing and layers and natural fabrics rather than synthetic ones. So go for your silk and wool and linen and cotton and not polyesters and things. And the same with bedding. I mean, you can get very good natural bedding fibers now. So, I mean, do look to things like that. And if you sleep with your husband or partner, consider having 2 duvets. He can have his nice big thick 12 tog and you can have a 3 tog one or something, but still be in the same bed.
For women who don't have any HRT and they're postnatal, are there any particular things you encourage them to do for maintaining sort of heart health, bone health, all of which obviously would have been aided by higher estrogen levels before they dropped?
Postmenopausal, yeah. I mean, there are women that don't have it, don't want to have it, don't have too many. I mean, I never believe women when they say, oh, my mother went through the menopause and never even noticed it, because I your periods are going to stop. You're going to know that something's happened.
Yeah.
So, the estrogens we know that women actually, if you compare women in the same age bands, and who are premenopausal and postmenopausal, you'll find that the women who are premenopausal have a lower risk of heart disease than the postmenopausal women. And it's lovely. I mean, it's a really, good study that was done showing this. We know that estrogens are very good for the cardiovascular system, for lipids, for blood flow through the arteries. And so, this is one of the risks of the menopause. And because we're living longer, of course, it's having more of an impact. When women only lived to sort of 60, they didn't have very long to sort of find out about this, really, I suppose. So heart disease, we know that's a real risk factor for the postmenopause, and osteoporosis, which obviously, you'll know a lot about. Men and women both lose bone density at the rate of about 1% a year from the age of about the mid-30s. And women have an accelerated loss of about 3 to 5% a year, which is maximal in the few years immediately after the last menstrual period. And of course, this is the real risk of a premature menopause. If women have an early menopause, they're going to be much more at risk of osteoporosis, of heart disease, and issues like that.
That just highlights the importance of the sort of strength training and cardiovascular exercise for general fitness, really, doesn't it, as we age?
All the things we do in physio.
Indeed.
Yeah, it's great stuff. Yes.
So I think we've gone through most of our questions we wanted to ask you. We'll then just ask you what your top tips are for going through menopause. We always ask a top tip question at the end.
Yeah, don't be frightened of it. It is going to happen to every single woman. You can't stop it from happening. So we do need to accept it. The women we really worry about, the women going through an early menopause, the very early menopause, who may not recognize it sometimes. Do get help, that you don't have to suffer. Find out as much information as you can. There is a lot of good information out there now. And the British Menopause Society and Women's Health Concern are really good organisations for giving you factual, well-researched evidence. So I'd really head for those. And Menopause Matters, which was started by a gynecologist from Scotland years ago, 25 years ago. Understand what's happening, realise what's happening. Don't be frightened of talking about it. There's a lot of good menopause cafes going on around the country now, where women are encouraged to meet up and talk about their menopause, because it's good to know that other people are having similar experiences. And I think as women, we're very used to sort of just trying to keep going with everything, aren't we? And putting one foot in front of the other. Yeah. And I think it's a really difficult time for women because, or it can be, women are having babies later now, and because we're living longer, they may have elderly relatives around as well. And we all want big careers and, get up the ladder. And so these poor women are struggling with their menopause issues while they're coping with young families and elderly parents and work as well. And it can be hard. It can be really hard. So look after yourself. Take time out for yourself, I think.
That's really good advice. Yeah, that's excellent. It has been so helpful, and you've just got a wealth of information for us all and our listeners. It's just been incredible how much we've packed into a short amount of time. So thank you so much for having the time to come and speak to us, because I'm sure so many people are going to benefit.
Good.
Yeah,
I hope so.
thank you very
I hope
much.
so. Thank you for asking me. It's been delightful.